Thanks, Derek. As we finish up, I think Dr. Scher probably has the most important presentation of the morning because it really is going to tell us what to do after we put all these devices in, whether we repair them endo or repair them open. Dr. Scher is professor of surgery. He's chief of vascular surgery, one of the co-directors of the HVI, an incredibly talented both open and endovascular surgeon, a good friend. So without further ado, Dr. Scher is going to tell us about surveillance after EVAR for aortic disease.
Thank you, Mike, and thank you for the kind invitation. It's a privilege to be part of this panel. It may be the most important presentation because I thought I had 10 minutes, so it will be short, and I'll get you to lunch quicker. So I have no financial disclosures, but some of the devices and pictures you're going to see are investigational, such as what had been shared by Derek. They're limited to clinical trials when used in the US. So in the way of a background, you've heard throughout this morning how EVAR and TVAR have become the first-line approach to treat aortic aneurysm. They have multiple advantages, as you have seen, because of lower morbidity and mortality, but they do carry the need for lifelong surveillance. Multiple complications can happen over time. You've heard about endoleak, which can develop overall in up to 25% of patients. And they're not just months after the repair or at the time of the repair, but they can also develop years after the repair, which can result in aneurysm growth and therefore rupture. Graft migration can also happen, as well as structural graft failure, which can include lymph outflow impairment with iliac stenosis or occlusion. Now, with the use of branched and parallel grafts, this includes another set of potential complications. Whenever you are using them for thoracoabdominal aneurysm repair, you will have to deal with some form of visceral branch stenosis or occlusion. And when you're using them in the arch, great vessel branch stenosis or occlusion can happen. So surveillance is mandatory whenever you're treating patients with an endovascular repair specifically, and the ideal surveillance modality should be non-invasive, cheap, reproducible with a high sensitivity and specificity to detect those endograft-related adverse events. Now, currently, for the most part, CTA is really the standard for long-term EVAR and TVAR surveillance, although there are some modifications for EVAR that you will see in the next few slides. So those are the different types of endoleaks that one has to deal with whenever you're treating an infrarenal aneurysm repair. The most serious ones are the type 1 and the type 3 endoleak because they do result in pressurization of the residual aneurysm sac and can lead to aneurysm growth and rupture. So type 1 endoleak is due to an incompetent seal at either the proximal or distal attachment site of the endograft. It can happen in up to 10% of EVARs. It can occur either immediately after placement or in a delayed fashion, and this is typically seen if you are deploying the device in a disease segment of the aorta, and that segment will dilate over time. It's always very important to remember, as Mike had mentioned earlier, that aortic disease is really a progressive disease, and repair is likely to fail, especially if the repair is done against the device instructions for use. So there's almost uniform consensus that a type 1 and 3 endoleak need to be repaired because of the risk of rupture, and this is reflected in the current guidelines of the SVS. And to share with you some of the examples that can happen that can be picked up with surveillance, this is an earlier generation of the Medtronic graft that has migrated. This graft is supposed to be all the way up here, and you can appreciate how the aneurysm is perfused, and this can be salvaged essentially by putting a newer generation endograft inside the first one to treat the type 1 endoleak. This is another situation here where the endovascular repair was done against sound judgment because this patient had no neck. If you look at the aneurysm shell, this graft is much smaller than the actual aneurysm neck wall, and therefore a type 1 endoleak is to be expected. And this was salvaged essentially by proximal extension by putting chimney grafts into the renal arteries to be able to extend the seal zone above the renal arteries. Now, sometimes the aneurysm degenerates around the endograft. You can see how beautiful the completion angiogram here after the repair was on the left side panel. But years later, the aortic neck degenerated, leading to a huge type 1 endoleak involving the renal vessels. and this was picked up on surveillance, obviously with the CT scan here, and this patient required open conversion. A type 3 endoleak is when the limbs disconnect, and you can pick that up easily on surveillance as well, and this can be bridged essentially by another bridge graft to seal the gap between the two stents. So the traditional follow-up schedule, if you look back at the original EVAR trials, is a little bit of an overkill because it initially called for very, very frequent CTAs at 1, 3, 6, and 12 months. If you do the math in terms of how many CTs you're doing, that's a lot of CTs. And what does that mean? This schedule is really was based on the initial endograft trials, but it made sense maybe 20 years ago with the first generation devices, but it doesn't currently make sense because of the improved endograft and our comfort zone essentially treating more and more patients over time. So too much reliance on CT scans essentially leads to too much radiation, which we have seen can result in malignancies, blood malignancies. Too much contrast can lead to nephropathy and renal failure, and of course it is very, very costly. We have shown a number of years ago that replacing the surveillance protocol for infrarenal aneurysm repair with ultrasound is quite safe, and this is our protocol currently at UPMC and across several centers, whereby we switch patients to ultrasound surveillance at 1 year if the CT does not show any concerning findings. And this eventually, so this was from 2009, and this eventually made it to the guidelines. So you can see a lot of details on ultrasound imaging. You can pick up all those endoleaks, whether it's a type 1A endoleak, which is from the proximal attachment site, and you can see it on the left side panel, a type 1B, which is from the iliac, a type 2 endoleak or from the lumbar or the IMA, essentially back bleeding into the aneurysm sac. So it is pretty sensitive if you have appropriately trained vascular lab techs. As I mentioned, this has made it into the guidelines, which advocate for the use of ultrasound at 1 year if there is no endoleak and the stable or shrinking AAA sac is seen at the 1 year CT scan. Now, even this may be a little bit of an overkill to do it at 1 year, because what we have recently shown is that if the residual aneurysm sac around the endograft shrinks to 4 centimeters or smaller, the risk of re-expansion over time is really quite low. In a series of 540 patients, we identified 166 patients in whom the aneurysm shrunk to 4 centimeters or lower. And essentially, the likelihood that this will expand over time was quite low. And if it is to expand, it usually happens within 3 years, which tells us that perhaps in patients in whom the sac has shrunk, we can increase the interval for surveillance to up to 3 years with ultrasound and therefore minimizing cost. Switching gears a little bit here to talk about the thoracoabdominal aorta, you've seen a lot of talk about fenestrated and branched EVARs, and outside the US, this has become really mainstay and they are frequently used, but in the US, they have been restricted to clinical trials or modification of commercially available devices. The follow-up schedule remains in this particular situation at 1, 6, and 12 months and annually thereafter with a CT scan, because those patients may have a different set of complications other than the ones that, in addition to the ones that I have shown. In this series from Seattle, it's actually from the Aortic Research Consortium, up to 1,681 patients were treated with a fenestrated and branched EVAR, and 23% of them required a secondary intervention. A lot of those interventions are related to branch vessel reintervention, but also to access site complications. The branches are typically durable. In this original series from the Cleveland Clinic, you can see that the freedom from reintervention is up to 98%, but there's clearly a finite need for reintervention at each and single one of the visceral vessels, whether it's the celiac, the SMA, or any of the renal arteries. And this is an example of what can happen. For example, you can see in the top panel how the SMA and the visceral stents are perfectly aligned, but then there had been migration of the SMA stent that you can see in panel C, resulting in a type 3 endoleak, and this required a bridge stenting. So this is the kind of thing that you can pick up on surveillance CT scan. You've heard from Derek how things have migrated into the aortic arch, and a lot of new challenges and exciting advances are in progress. Those two devices were recently approved by the FDA in 2022 for the hybrid repair with the Thoraflex graft or the TBE graft by Gore. And whenever you're migrating essentially the endovascular repair into the aortic arch, you have to be cognizant of the great vessel complications and the need for surveillance. As I've mentioned, in Europe, the aggressive use of endovascular technologies is more mainstay, and this is actually reflected in the European guidelines, whereby aortic arch debranching and endovascular repair, the vascular gymnastics, I'm going to borrow that term, can be done essentially to treat the arch pathology with endovascular repair. To share with you one case that was recently done essentially as a compassionate use at UPMC as part of a clinical trial. This is an 83-year-old man who had developed a mycotic arch aneurysm that was treated by Dr. Macroon. He presented with chest pain. The CT essentially was suspicious for mycotic arch aneurysm, and it fitted the clinical picture of a prior incision and drainage of a left knee swelling. He was turned down for open surgery and returned with more pain and expansion of the aneurysm a few weeks later. And this is what the CT scan essentially showed: the progressive increase of this aneurysm over a very short period of time, worrisome for mycotic arch aneurysm. Older gentleman turned down for open repair, and this is essentially what was done. Another case of vascular gymnastics that relied essentially on a single branch, zone 0 repair that was placed into the innominate with debranching of the carotid and endovascular repair to exclude that mycotic aneurysm, and it seemed to work. Perhaps the exception rather than the rule for mycotic aneurysms. This is another case where surveillance can be very important in the aortic arch. This particular gentleman had been treated for a type B aortic dissection, and the false lumen continued to expand over time with an endoleak here around the proximal fixation site, resulting in a growing thoracic aneurysm, and this required more proximal extension, essentially using the TBE endograft to preserve flow into the left subclavian. So whenever you're doing surveillance for total endovascular repair, you have to keep in mind disease progression, endoleak, migration, stent fracture, component separation, but also branch stability, which can be very critical in the aortic arch and in the visceral segment. So to summarize, essentially for EVAR, you need a CTA at 1 month and at 1 year. And if that looks fine, then you can switch to an annual duplex ultrasound, which is what the guidelines call for. Perhaps in those patients in whom the aneurysm shrinks to less than 4 centimeters, you can increase your surveillance schedule to up to 3 years. But always keep in mind the association with thoracic aneurysms, and perhaps to doing a CT scan at 7 years to look for thoracic aneurysms in those patients who were previously treated with a AAA. For TEVAR, following TEVAR, the guidelines call for a CT at 1 month and 1 year, and then yearly thereafter. For the arch and thoracoabdominal aneurysm, there are no guidelines, but as it is now, it is a CTA at 1, 6, and 12 months, and annually thereafter. Thank you very much for the invitation, and I look forward to your questions.
Thank you.